Chapter 8, Skin, Hair, and Nails. So the function of the integumentary system, also called the skin, hair, and nail system, gives us information about an individual's overall health status just by looking at them. And in the integumentary system, the two nursing skills that are used for this particular system are inspection as well as palpation. We're not really using percussion, we're not really using auscultation for this system. So the anatomy and physiology, just so please go back to your anatomy and physiology books and review the different layers of skin, the epidermis, the dermis, as well as the subcutaneous tissue, and then differentiate, between the vellus hair as well as the terminal hair. And remember, it's the dermis of the skin that has a lot of the connective tissue, all the sensory nerve fibers, capillaries, collagen, as well as elastic. And it's this part of the skin that provides the structure of the skin, where the dermis is that top layer that sheds every couple of weeks. And then with the vellus hair as well as the terminal hair, the vellus hair is that fine, kind of soft, kind of peach fuzz hair that's found all over, the body, that sometimes provides more of it provides warmth, and it's kind of through evolution that vellus hair has always been around, where terminal hair is, what we find on our head that, grows and then it falls out and it just constantly reproduces. With nails, you have your cuticle, your lanula, as well as your nail beds, and it's the cuticle that acts as a protective seal and prevents any bacteria from entering this underneath the skin or the nail bed. The glands that affect or impact the integumentary system, we have our sebaceous glands, as well as our sweat glands. And our sebaceous glands are those glands that are found over the entire body, and that produce kind of a protective oil that keep your skin moist. Your sweat glands are both your eccrine as well as your apocrine. Your eccrine glands produce sweat, but it's that odorless sweat that you produce, where the apocrine, the apocrine, produce that body odor type of sweat, where it has a scent to it, to just differentiate and know the difference between those two. So diagnostics with the skin, in terms of, what's going on with the skin, if there's a lesion of some type, one of the quickest ways to kind of figure out what's going on is to actually biopsy the skin. And that's just taking a piece of that tissue that's impacted and sending it to the lab for microscopic evaluation. And a skin biopsy will help to identify any diseases, any infections, and more importantly, any skin cancers that might be present. So let's start with a question. A college student experiences a very painful paper cut to their finger as they turn the page of their textbook. What layers of the skin are affected? Is it the dermis, epidermis, epidermis and the dermis, or all three, epidermis, dermis, and subcu? It's actually C. It's both the dermis as well as the epidermis. So we know it's not the epidermis because sometimes we'll shed a little bit of skin, but it didn't break through. Once you break through the skin and there's some bleeding, that's when you've gotten into the dermis part of your skin. So let's start, our physical assessment on this patient. So we always want to start with collecting health history from the patient and identifying, are there any, is there a review of anything either in their medical history, their personal history, surgical history, family history that could lead them to be susceptible to some type of skin manifestation. So we want to ask a lot of questions, and a lot of the questions could result from the way they take care of their skin. What type of detergents do they use on their clothes, because that can impact their skin. What types of soaps do they use on their body? If they use deodorant, what kind of deodorant do they use? How often or how frequent do they use? How do they take care of their hair? What type of shampoos do they use? If they're complaining of dry, brittle hair, could it be the shampoo that they're using? Could it also be dehydration? Could it be that they are lacking certain proteins to help support? Maybe they need additional biotin in their diet. How are they taking care of their nails and their nail beds? What type of nail care do they do? Do they go to the salon once a week? Do they go, every couple of months? Do they take care of their own nails? Medical and family history. So refer to box 8.1 to kind of identify, what type of genetic disorders are there. So acne is genetic. So, if parents had acne, they're more at risk for developing acne. Skin cancer is another big one, any type of skin malignancies. Eczema, lupus, psoriasis, as well as any type of dermatitis. So what does their family history look like? What about their medical history, their surgical history? Surgical, we can kind of figure out, have they ever had any surgeries that has left a scar? Because when we see a scar, we kind of want to, be prepared that scar is related to, a surgery that they had on their knee or their ankle, or it might be a C-section scar. And then what type of allergies do they have? Or do they get a skin reaction and they're not quite sure what that reaction is? And could it be an allergy? So you want to ask about what allergies they might have, or if they're aware of any. And then going back, to just how they take care of their skin. What type of skincare and health promotion practices do they incorporate? Do they go to the dermatologist annually, or do they do their own skin check once a year? When they go out in the sun, do they use sunblock? Are they more susceptible to burning? So do they know how to use sunblock? When to use sunblock? At what time of the day do they use sunblock? Do they suntan? Do they self-tan? Do they go to an indoor tanning booth? We also want to ask patients about any changes that they've had with their skin. Have they noticed any changes in coloration, yellowing, jaundice, cyanosis, or bluing, or paler type color to their skin, or albinism, or a white lack of color to their skin? We want to ask them if they've noticed any changes in their skin texture. Is there a patch or an area of their skin that's dry, soft, scaly, more swollen, flaky, or rough? Have they noticed any new skin growths, skin lesions, any new rashes? When we're asking about their hair, we can ask them about, what type of diet they're on. Are they under a lot of stress? Because those could create, dry, brittle hair. It could also result in loss of hair, or alopecia. What about genetics? Do they have a history or a family history of alopecia, or hair loss, or changes with hair coloration, or hair brittleness? Is there an infection anywhere on the scalp or around their scalp? And any endocrine disorders such as hypothyroidism. Hypothyroid can cause hair loss and dry, brittle hair. Do they have a family history? Have they noticed a change in texture? Have they noticed that it's more dry or more oily? Have they noticed frequent breakage? And then same thing with the nails. Any changes with the nails? Any changes with their nutrition? Are there any stressors with regards to, vitamin D, vitamin A, vitamin C, or even iron? Iron intake could, lack of, or anemia can cause dry, brittle nails. So let's start with another question. A chief executive officer for a large manufacturing company reports that they have noticed that their hair is falling out and breaking when they brush it. What should you ask? What should you do next? Should you ask if there's a family history of hair falling out? Should you ask if they're under a lot of stress? Should you ask if they have an endocrine disorder? Or should you go through the OPQRST or cold spa or oral carts mnemonic to gather more information? The answer is D. Start from the beginning. There shouldn't really be any assumptions. You can kind of assume that maybe they have a very high stress job, but you want to start from the beginning. How long have they worked at that corporation, and when did they start noticing that their hair is starting to, fall out and break? And, what is there a pattern? How much are they losing in terms of the quantity or the quality? And what are they doing about it? So with our physical assessment of the skin, hair, and nails, we want to use that systematic approach from top to bottom. And again, the only two systems that we're going to use, or skills rather, is inspection as well as palpation. And we want to compare from side to side and have good lighting. We also want to make sure that we're maintaining privacy. We're only exposing the areas that we're assessing. We're not exposing the entire patient at one time. So for example, if we're just looking at their arms, we're only exposing their arms. And we're asking permission, especially in those areas where they might be a little private or timid to show. We also want to take into consideration any culture or ethnicities in terms of findings normal for that population. So an example is dark-skinned persons tend to have lighter tones of skin on their lips, their nail bed, and their palm, and that's normal. It's a normal finding. We definitely want to also look at their conjunctiva. When we're doing the HENT, we'll go a little bit more into detail. Want to look at the palms of their hands and their mucous membranes for any changes from what they consider their normal. With the inspection and palpation, we're looking for any changes with their skin or anything that seems concerning. So of course we always want to use gloves if we're looking at their skin and identifying any lesions that might be weeping. We want to include a tape measure if we have to measure a lesion and we have to document on it. Using adequate lighting and then maybe even a magnifying glass to help us get a better view or a better picture of what we're taking a look at. So with inspection, we want to inspect their skin and kind of do an overall view of what their personal hygiene is. Are there any odors? Do we sense any odors? Body odors or even breath odors? What does their skin coloration look like? Look at side to side. Know these terms: no cyanosis, pallor, jaundice, albinism, keratonemia, erythema, hyper and hypopigmentation. These are all important terms to use when we're starting to document, and these terms will always come up, and I expect you to utilize those terms when you're doing an assessment on your patients. You want to compare the temperature and what part of the hand we're using. We're using the dorsal part of the hand. We're assessing the skin temperature, comparing both sides at the same time, assessing for thickness of their skin. Turgor, the best place for turgor to determine hydration status is right in that area between the clavicle, or you can also use the hand to see if there's any tenting. And then moisture, just kind of feeling if it's moist or dry. When we're looking at moles, or nevi, also called nevi, we're going to use that A, B, C, D mnemonic to assess. A is for, is it asymmetrical? B is for looking at the borders. C is looking for color changes. D is for any changes in the diameter, and anything greater than 6 millimeters is usually very concerning. And then E, evolution over time. We're looking at rashes, lesions, scars, any masses. We talk about lesions in terms of primary, secondary, and vascular. And your primary lesions are those lesions that didn't erupt from anything else. And you've got Table 8 in your book really goes into what the lesions are, an example of what the lesions look like, and what they look like when comparing from the dermis to the epidermis and maybe even the subcutaneous. Your more common primary lesion is your macular, and that's macule rather, and that's your typical mole. Your papular is more of a solid elevated spot. It kind of appears a little bit rough, dried over, and it's a little bit larger than your macule. Your patch, your plaque are other common ones. Your vesicle is more of a blister type. A great example of a vesicle is a herpetic lesion, a cold sore, and a vesicle that erupts is then considered a crust. So again, primary lesion will turn into a secondary lesion when it changes formation. And these are examples of your secondary lesion, and these are progressive changes with a primary lesion. Progressive changes or changes related to trauma or injury. And just refer to your Table 8.1 to gather some examples. And again, like I said, a crust is just an example of a herpetic vesicle that ruptured, and now it's starting to dry over and it's crusted over. Fissures, a good example of fissures are the dry heals that start to separate. Scars is a secondary lesion that's related to surgical. And keloids are the thickening of a scar tissue, sometimes found in more of the African American population. When documenting on lesions, you definitely want to use the correct terminology, but you also want to talk about the distribution of the lesions. And Table 8.2 does a really good job in explaining and demonstrating how the lesions are distributed over a body, whether they're diffuse, localized in one area, or generalized. Are they in hairy areas? Dermatome is if it's on a nerve, and that's a good example of a dermatome lesion is shingles, because it's painful. It's a herpetic varicella viral infection that creates the vesicles, and the vesicles are actually on a nerve line, and that's why it's very painful. The pattern and configuration is also important. Is the lesion round? Is it discrete? Are they grouped or confluent? Is it in a line? Arciform, I can never say that word. Arciform. Is it an iris, reticular, or is it gyrate? And Table 8.3 also goes into that distribution. So another question. You're performing a skin assessment on your patient, and you note an irregular red lesion under a patient's left armpit. Which equipment will you need to assess that lesion? And another question I would say is, we would call it a red erythemic lesion. So, which equipment do you think you'll need? So select all that you believe are to be true. If you picked A, B, C, and D, you are correct. A sterile cotton-tipped applicator is not necessary, because you're using inspection to assess this lesion. So normal findings when you're assessing skin, you want to document their hygiene, whether or not there are any body odors, uniformity with color, moisture, skin turgor greater, skin turgor less than 3 seconds, no abnormal lesions, any moles are kind of symmetrical, brown, small, and haven't evolved into something different and very irregular. where abnormal findings are what you see right here. Skin turgor greater than 3 seconds or tenting greater than 3 seconds can indicate dehydration. So question 3. A bullseye lesion or round lesion with central clearing is typical of Lyme's disease. What is the name of this lesion's pattern? It's an iris. It's kind of like the iris of your eyeball, right? You've got that center pupil, which is kind of the bullseye, and then it's red all around. So that's a typical, picture of a Lyme's disease lesion. So inspecting as well as palpating the hair and the scalp. So the purpose of this assessment is to determine any changes or abnormalities with the hair and the scalp. Inspection of hair should include body hair, scalp, axilla, as well as pubic hairs at about an inch interval. So you're really looking, you're separating and you're looking. And if you don't do that, you're not doing your patient a service by doing a proper hair and scalp assessment. So with this, you definitely want to put gloves on because you don't know what you're going to find, and you're going to look at the amount, the distribution, as well as the cleanliness. Look for any areas of dryness, flaking, oiliness. Look at the hair color, texture, and identify any lesions that are on the scalp. And you're also going to palpate their scalp to see if there's any pain or discomfort. You're going to look to see for normal findings whether or not their hair is clean, curly, or straight in texture, and then the thickness and distribution of their hair. Abnormal findings would include thin, brittle hair, any lesions, any balding areas or alopecia, any folliculitis or acne pustules on the scalp, or any fungal infections such as tinea capitis or tinea vesicular. And then you're going to palpate and inspect the fingernails and the toenails. And this is, again, to identify any nutritional deficiencies, malnutrition, diseases, or infections. And you're inspecting for general coloration, nail bed shape, contour, care of the nail and the nail bed. And for palpation, you're just assessing the capillary refill to determine is there adequate blood flow and supply to the hands and nail beds. So again, normal findings with nails include nails that are smooth, uniform, have like a 160-degree angle, that they're not clubbed over or brittle and flat, that they're firmly adhered. And if you can see their nail bed, if they're not wearing any nail polish or nail covering, that their nails are pink. And if you're not able to, you want to also look at the pads of their fingers, and that gives you some information as to the pinkness. When assessing wounds, you want to look for signs and symptoms of healing, inflammation, or infection. Equipment to use when assessing wounds includes your personal protective, your PPEs, as well as any dressing or supplies that you're going to need if you have a wound that's covered and needs to be reassessed and then redressed. Paper tape measure to determine the size of the wound, if there are any changes with size, if it's gotten larger, smaller. A pen light to help you see, as well as a sterile cotton tip applicator in case there's any drainage that you need to send out. When you're looking at wounds, you want to identify the wound location, the perimeter, the wound edges, and you want to document in centimeters. Okay, and that's where you would use your measuring tape. And you want to measure the length, the depth, the width, if you're able to. Normal findings of a wound, if there is a wound, it shouldn't be red, it shouldn't be draining, and there should be no inflammation or edema. The wound should get smaller or start to heal over and become lighter in coloration. Wound types include abrasions. It's kind of like a rug burn almost. Abscess, which could, start under the skin and then evolve as a large mass, and that mass could rupture. Contusions, crushings, excoriations, incisional wounds, lacerations, which is just tearing of skin. Penetrating wound could be a gunshot wound, punctures, which could be like a stabbing or a knife wound, and then any tunneling where you have maybe a surgical incision, and then if you take your sterile tip applicator, you can actually go underneath, and that tells us if there's any tunneling to the wound. Pressure ulcers, this is mostly, for patients in the hospital or bedbound patients or patients who are in assisted living. And when you're assessing pressure ulcers, you need to identify any, signs for healing as well as signs of inflammation or infection. Pressure ulcers, kind of already know that they're caused by unrelieved pressure to a certain area, more so than not on, where there's a bony prominence. And again, individuals who are most at risk are those who are immobile, have poor nutrition, where they're not able to take in enough protein for wound healing. They're confined to a bed or they're confined to a wheelchair. There's decreased circulation. And we would need to use the Braden score in order to score what type of wound ulceration they have. And there are different types of pressure ulcers. You have your stage 1, which is just more of has to do with more of the dermis. It's blanchable and the skin is intact. When you suspect a wound, if it might be more difficult to see it in persons of darker skin. So if you do suspect that there might be a stage 1, assess the temperature. Usually it's a little bit warmer, more tender to touch. So look around, feel around the wound, and kind of identify that, and then get that person off of that area so that it doesn't progress to a stage 2, partial thickness, full thickness, a stage 3 rather, and then or a stage 4. When you're assessing a pressure wound, you want to, as always, measure it, identify where it's located, measure the width, the length, and the depth, determine if there's any tunneling or undermining, to that wound and where that's located. You're looking for inflammation, amount and color of any drainage that there is, if there's any achar or kind of like that black dehydrated necrotic tissue. Is there any tenderness, new tenderness, old tenderness, or is it macerated? There are a couple of tools to use, one of which is considered more of a reliable tool by the NPUAP, which monitors changes in pressure ulcers over time. And the push tool measures the length and the width, the amount of exudate, as well as the tissue type that's involved. So question 4, you're assessing a patient who doesn't walk and spends most of the day in a wheelchair. They complain of left buttock pain, and you put them back to bed and see a large excoriated, macerated, open area on their left buttocks. It measures 3 by 4 by 0.5 centimeters. What stage is this? If you said stage 2, you're correct. It involves both the dermis and the epidermis, but you don't see bone, you don't see muscle. And then, of course, health promotion. We want to make sure that we're teaching our patients to, see a dermatologist at least once a year, and to learn how to assess their skin, for any abnormalities, changes. Limit their sun exposure, preferably between the hours of like 10 and 2, when the sun is probably at its, most, the highest, and they're more at risk for ultraviolet light exposure. And then you want to teach them about how to examine their own bodies, not only to be seen by the dermatologist, but also to examine themselves. So, question 5. You're assessing a patient's skin and note a silvery scaly plaque on their knee and bilateral legs. They report that they have a chronic immune disease. Which condition do you believe this patient has? If you said psoriasis, that's correct. Psoriasis is a chronic immune disorder, usually around the legs, the knees, the elbow areas, and it's chronic, meaning it's, ongoing, and there are some good biological agents that will help put them at rest. And then our last question. You're assessing a 60-year-old patient who tripped going up the stairs. They report 4 out of 10 left leg pain and have a large 7 by 7 cm bruise on their right lower shin. What is the term for this type of bruise? And the correct answer is ecchymosis. Ecchymosis is just a bruise caused by bleeding underneath the skin. A cherry angioma, those are little red vascular lesions that you mostly find in the older population. And then a hematoma is just a collection of blood, and it's pooling underneath the skin. But an ecchymosis is more so a bruise that is no longer bleeding.